think we're going to get started. Thank you all for coming. This is the second interprofessional event that we have had here with CHRP, and this year is a little bit different. We have the School of Public Health also involved with us today. And the last time we did this, we had an actual 38-week pregnant woman. So today there is no actual patient, but you've all had information ahead of time on what the actual case summary is. And we're hoping to have an exciting and fruitful day today. I would first like to have a welcome from the Dean of CHRP, Dean Alan Lewis.
Thank you very much, Professor Laffin. Everybody, thank you for being here and all the work that's gone into this up to this point. As Professor said, this is our second year of doing this. We did it year before last. And the goal of this is really for us to understand more clearly interprofessional education and how different disciplines come together in an integrated way to offer more effective services because of the collaboration that happens across discipline-based lines. So I know we have a lot of folks to thank, and I'm going to thank those folks now because this kind of event isn't possible without a lot of hands on deck. And first and foremost, I want to thank you students for being willing to participate in this. And I know it's one of those things you don't know exactly how it's going to be early on. You kind of have to take a risk and say, okay, I'll do it. And so thank you for this. Last time we did this, we didn't have nearly as many students involved. It was the first time. So we mostly had faculty sort of leading the way and talking about what their respective disciplines would actually do with the case that we were looking at that point. So now we've evolved to actually having students much more involved. And as we go forward with more of these events, the key is for you all to think about what things you might change going forward to make this a much better endeavor. In the interest of continuous quality improvement, we always have things we want to tweak as we go forward to make things even more beneficial to us. So with that, I'm just going to thank a few folks who've been involved in addition to your students. Professor Jennifer Ote, who has been involved from the PT program. Yay, okay. Professor Douglas Dunstatter from DMI, Diagnostic Medical Imaging. Dr. Judy LaRosa from Public Health. We have some public health students also involved today. Professor Mary Ann Laffin for her leadership in pulling this all together. Second year in a row. Thank you, Mary Ann. Professor Felix Wamagina from the PA program. Dr. Farhad Harari, growing the beard with the new look. Looks good. Professor Richard Sable, OT, yep. And of course, we know Dr. Harari's from PT as well. We know that. Dr. Addie Jumbo from Medical Informatics. Program Administrator Kamika Falconer from Diagnostic Medical Imaging. I think she's maybe outside at the desk. Assistant Dean Philip Bones from the Dean's Office. We want to thank our folks from Marketing and Public Relations, Houstoniv and Howard, who's from Classroom Services, Howard Erskine, for being here with the technology so we can capture this moment in time and look at it later. And with that, I will say let's get started. And thank you again for coming out.
I'd like to ask Dr. Judy LaRosa from the School of Public Health to say hello to everyone.
Thank you, Dr. Laffin. This year is a very interesting one because we have public health involved. And you're going to say, what the heck does public health have to do with somebody who has to go home and they're out of PT and all that kind of stuff? Well, because they're going back to their community. And we need to find out what is the best way to help people in the future in their communities. So there are only 3 of our students here today, unfortunately, but they're going to be rotating to the different groups and talking with you about how public health, you can work to enhance what you're doing and to make it better for patients and people in the community. So we thank you very much, and I follow Dr. Lewis, and I thank everybody who's been a part of putting this all together. Thank you.
We've written up an agenda, and everyone should have picked up a copy at the sign-in sheet outside. So interprofessional education, what exactly is interprofessional education? According to the World Health Organization, it occurs when students from 2 or more professions learn about, from, and with each other to enable collaboration and to improve health outcomes. So that's our goal for today, to help you learn to work collaboratively with every other profession that's in this room. And there are a lot of other professions that are not in this room, but we have the ones that are here in CHRP and the School of Public Health. The word interprofessional has a number of AKAs: interdisciplinary, multidisciplinary, intercollaborative practice. They all mean the same thing. It's patient-centered care that is critical to keeping our patients healthy. It's a partnership with patients. Patients are at the center, we have shared decision-making, and we have respect for each other as professionals. Everyone brings their own knowledge to the table for this. So when you talk in your groups, you can also think about what other professionals would have been at the table in the real world with you. The patient summary, everyone should have a copy of this and have already been familiar with it when they did their pre-work with their professions. Medical informatics is going to come and talk to us a little bit about the role of medical informatics in this case summary.
Did I really have to go first? Hi, my name is Erica. I'm one of the representatives from the class of Medical Informatics. So what is medical informatics? Medical informatics is the connection of information science, computer science, and healthcare. This field pretty much deals with the resources, device, and methods that is required to use to improve the use of information in healthcare and biomedicine. So as you guys know, we are living in a modern time, and medicine is becoming more modern. So many organizations are going paperless and implementing electronic health record system. However, there are some organizations who aren't quite ready to go paperless, and this is where our job as medical informaticists and system analysts are here to help them to implement the EHR system, electronic health record, to help improve and pretty much, I'm sorry guys, I'm so nervous. I'm not really good at public speaking, but yes, to help organizations transition to an electronic health record that is feasible and useful to bringing quality care to patients. So based on this OBGYN case study, once the patient comes in, the patient is admission through check-in. Our job is really to create an application task in the EHR system that helps clinical workflow. So the patient comes in, the patient is checked in by the registered clerk. So as you can see, the patient list and their name is showed up. Next, an order is placed for the patient by the provider. And you can see we created a tab for orders, so you can see the patient's laboratory order in order to check for the beta HCG levels, radiology for their ultrasound. Next, in the EHR system, if the patient or there's a tab where the nurse and providers can document the patient medical health issues. And the patient then gets assessed by a nurse who collects information on the patient vital signs, so known habits, allergies, active or past medication history. And here, once the patient is assessed, their vital sign is assessed, they get their lab work done. So a lab results, we created a lab results where in the EHR system, you can tell whether or not if it's created in red, you know, the labs are abnormal versus normal. And also in the EHR system, our job is to create, like I said before, application to help with the workflow. So we embedded a PAC system within the electronic health records so that the patient can access, or the provider actually can access the patient's results such as the ultrasound. So not only the lab results, but also like ultrasound exams, their imaging. And then once the patient have finally been assessed, then a clinical summary is provided for this patient and sent to their provider. So in this clinical summary, the patient's biometric, the fetal biometric, all measurements are shown, and their ID are shown. So really, our job is for the EMR system contains useful functions to efficiently provide quality care for patients, if that makes sense. I'm sorry for my nerves, guys. I didn't expect to be first, but that's pretty much it. So our job as medical informaticists is really to implement applications in the EHR system so that we can have a better workflow for providers to get into providing care for the patient rather than a paper chart. Whereas if the midwifery was occupying a patient's paper chart, the radiology wouldn't have access to it. So it's like one person, whereas with the EHR system, multiple providers can have access to this one patient file. So that's pretty much it. Thank you.
Alrighty, my name is Jake. I'm a physician assistant student, working obviously in the 7th floor there with everybody. What is a physician assistant? A physician nationally certified, state licensed. Obviously, we don't do everything that what a doctor does, but we don't do, we pretty much copy a lot of what they do. With certain different things, like obviously we conduct physical exams, we diagnose and treat illnesses, we order and interpret tests. Obviously huge for this case. We want to be able to make sure that this woman is stable. And I think a lot of it, is just about increasing access and the quality of care to a lot of people. At the end of the day, physician assistants started out in around the 60s to increase access to the growing population of people in like the baby boomer generation. So we do have a lot of, there's a lot of need for it. And I think that PAs obviously fulfill that role and get people, increase access and increase the quality. At the end of the day, we want to care for the patient. We want to allow the patient to live as long as we can. We also want to be able to make them improve their quality of life. I think that's a huge thing that can get kind of overstated in this sense. So I think PAs, obviously we do, one of the big things, we don't generally do surgical procedures. We do it with the assistance of the doctors, so we can't go in and kind of do it on our own. And obviously we report to the doctor. So we're not doctors, we're not trying to replace doctors, we're trying to work with them, okay? Because I think that's so important, decreasing the burden that a lot of the doctors have. Because at the end of the day, you've got to be on a healthcare team, we're all part of the same team, so. Okay, cool. So obviously states with the largest number of licensed PAs. 5 out of the 6 here are the largest states with the highest population in the country. So it makes sense that in order to fulfill that gap in certain areas, obviously here in New York, we need to increase the access so that it makes the lives not only of doctors, but most importantly, the patients' lives better, because it's a multifaceted approach. We can't just do it. The doctors can't do it alone. Neither can other healthcare providers. So it's really is a team effort, and in these states particularly, we see largest number of licensed PAs. All right, and these are just some facts about PAs. Anything here? It's really it's kind of a newer field. Like in the '60s, it was they had a lot of people taken out from the military. So it's really somebody who is maybe doesn't want to go as long as medical school, but kind of is the next step for people. Like a lot of our classmates were EMTs and whatnot, and so they want to take the next step, and they're like, hey, I think this is really valuable. Then hey, let's why can't I take my next step and really care for patients? Because that's what that's what we do. And in this instance, managing, we can work with any type of patient population. There is no specific. We work in all different types of fields, so that kind of gives us a great sense of flexibility. Hey, we can do in this, we can work in this field, and obviously there's a lot of PAs in the OBGYN field. And the most important things with the PAs that we want to start with a focused history and a comprehensive physical exam. I think that's absolutely crucial in order for you to kind of diagnose and treat the illness, which is what we're there for. So we really do take physical exams. We take patient histories. I think it's extremely important for this this scenario in particular that we're really looking out for the patient here and trying to get a sense of, all right, what's your background, what's going on, why are you here, how can we help you? So obviously we're ordering labs. We're also interpreting labs and diagnostic studies, which I think is huge. We do play a part in a lot of that stuff, and we refer to specific healthcare providers as needed. And at the end of the day, we also want to be able to provide information on health promotion and disease prevention. So we want to be able to counsel patients on what to do, what not to do, what's the best approach and how do I, improve my quality of life. So, and that's it. And now we get on to our midwifery program. So.
Hello all, my name is Caitlin. I'm a midwifery student. There should be about one of us in every group. So just to talk a little bit about what midwives are, they're licensed in all states. There are currently about 1,200 midwives licensed in New York State alone, and 220 of these are in Brooklyn. So what is a midwife? We are licensed practitioners. We're providing a full spectrum of care for women and their families from the full timeline, from preconception to pregnancy, labor, birth, postpartum, their annual gynecological visits, and also many aspects of primary care. We believe in a holistic approach. We take into account the clinical, the social, and the cultural aspects of clinical care. We also focus a lot on optimizing the normal physiological processes that women go through, as well as a women-focused, women-centered, respectful care in order to strengthen our patients' own capabilities. We believe that everyone has a right to equitable, ethical, accessible health care. We are very focused on respecting human dignity and making sure our patients are fully informed in order to make the best decisions about their care. So some things to take into account from a midwifery perspective when we're discussing our case today. To remember that the abdominal organs in pregnancy at this state, she's 38 weeks, they're going to be pushed to the sides. So that's something to take into account. At 38 weeks, you also want to be focusing on the state of the fetus. So at 38 weeks, you would be doing, regardless of the patient's state, a biophysical profile, which can include a non-stress test, electronic fetal heart monitoring, a fetal ultrasound, and also a GBS culture. So these are things that we want to keep in mind when we're thinking about this case from a midwifery perspective. What we'll also be focusing on is to assess the position, and this is a midwifery maneuver to help assess the fundal heights, the size of the fetus, where the fetus is positioned, and how they're doing overall. So some things to keep in mind from a midwifery standpoint. We want to decide at this case management meeting if we want to discharge the patient. That's a decision that we need to make as a collective group of clinicians. We want to be discussing the pros and cons of a vaginal birth versus a C-section. We also want to think about after the birth, down the line, the integration of midwifery care with OT and PT. How is she going to be doing breastfeeding? How can she, what will her movements be like to be able to change diapers? What do we need to think about where she's living? So these are all things to think about from a midwifery perspective. And yeah, I think that's about it. Thank you.
Hello, everyone. My name is Marcella, and I'm a student of the Diagnostic Medical Imaging program. So what is sonography? Sonography is a diagnostic medical procedure that uses high-frequency sound waves to produce dynamic visual images of organs, tissues, or blood flow inside the body. So based on the patient's signs and symptoms, 3 different ultrasound exams need to be performed. So 1 is the carotid Doppler, 2, an echocardiogram, and 3, obstetrics. So for those of you who haven't seen an echocardiogram, this is what it normally looks like. As you can see, it's a 4-chamber view, and the color that is presented in the video image is demonstrating blood flow and direction. So here we have a carotid Doppler. So the carotids are Doppler to check for narrowing of the vessels, just to make sure everything is running smoothly. The color, again, represents the direction and color flow. Then obstetrics, obviously, because the patient is pregnant, this is just to keep in mind. We're going to make sure the baby is getting all the nutrients via the umbilical Doppler. And we also have 3D and 4D ultrasound and live ultrasound. So there's different types as well. And yeah, thank you.
Okay.
So we're missing a slide. Hi, so we're from Occupational Therapy Department. So we don't have a definition, but there's a definition on your handout. And hopefully you'll kind of get the gist of it as we're speaking about our intervention plan. In occupational therapy, we really try to focus on our patients using a client-centered and holistic approach. And one of the models that we use is known as the PEO model, and that takes into account the person, the environment, and the occupation, and how that all influences someone's occupational performance. So with this client specifically, we really want to take into account what is important to her, and what will be important to her as her new role as a new mother. And then we also want to take into account what functions in her, what will hinder her, or what's going to help her in her functions in everyday activities. So since we're looking at this client in an inpatient setting, we want to take into account the limited amount of time that we have with her. So we really tried prioritizing our intervention based on what's important to her. So we wanted to take a look at dynamic balance with functional reach, weight shifting, independence in activities of daily living, which is what we call EDLs, such as toileting and bathing, childcare, and the education for the client.
Okay. So to address these intervention goals, here's a bit of a sample session that we would do with treatment in inpatient. So we'd start out with the preparatory activity, which is many of you may know is more like a therapeutic exercise to get her warmed up and ready for her occupational performance. So in this case, we chose scapular mobilization, which can help prepare for reach, and it'll get into the scapulohumeral rhythm, as well as Tai Chi, because it's kind of a fun activity that will work on her weight shifting, as well as like bilateral upper extremity use for push and pull. Then we'll work on functional activities that will address the underlying clinical deficits that the client has at the moment. And since she's pregnant and will be home with the baby soon, we decided to focus on changing the baby's diaper. And this will also address her clinical deficits, sit to stand transitions we can work on ways to transport the baby, as well as her dynamic standing balance and objects she may need to reach for while she's doing the diaper change. And throughout all of these activities, we'll constantly be educating the client, because as OTs, we're constantly thinking of discharge and the next step, even from our first session with them. So in the case of this client, we will educate her on energy conservation strategies, body mechanics, and visual compensation for the sensory deficits. And Farnaz will now take you through a little bit more detail of the intervention that we're working on.
So this is our client. And as Christina mentioned, we would do scapular mobilization because she has mild hemiplegia. We want to make sure her scapulohumeral rhythm is maintained on her right side, even though in the picture it's her left. Sit to stand, this is basically just demonstrating that there's proper body mechanics, and we don't want her to strain her body as she goes from sit to stand. Weight shifting would be done through Tai Chi, and this is something that we do in occupational therapy as a means of practicing weight shifting. So since she was hesitant to stand on her right leg, we want to make sure that we practice distributing the weight evenly, because we want to prevent any falls or other safety concerns. We also would be able to work on trunk control and balance through Tai Chi. And again, as Christina mentioned, we would work on changing a diaper as a functional means of working on goals. So here you see the therapist is ensuring that she's using proper body mechanics as she's handling the baby. Her knees are bent, her back is straight and not rounded, and we want to make sure that the client is breathing throughout the activity. Here again, she's lifting the baby. So in the case she is using a cane, and in the case that she is still using the cane after the birth, we want to teach compensatory methods of carrying her baby safely. So for example, she can use a baby carrier, and this is something she would wear, but we want to make sure that the baby is inserted into the carrier as she's sitting to make sure that she's balanced. She can also possibly use a stroller around the home to be safe. And then this is body transfer mechanics in action.
Great, so just to briefly summarize, what we would do in our intervention are preparatory activities or therapeutic exercises to prepare the client for her occupational performance. We'll address her underlying clinical issues through functional activities that will address the roles she's going to be taking on. And we'll provide education to help the client build awareness and feel more safe and confident when caring for her baby at home. So all of these things we're doing with the hope of increasing her independence and preventing further injury. And PTs now. Thank you, guys.
We're PT students here. So basically we also don't have a slide telling you guys about what PTs do, but we took the case study and kind of made our presentation based off of the case, so hopefully you guys will get a good gist of what's going on. So basically, PTs take a medical diagnosis and they look at it from the standpoint of impairments. And from impairments, we derive activity limitations and base our treatment accordingly. What I can say is we do develop exercise interventions in combination with manual therapy to help improve a patient's function. So based on the case study that we were all presented with, these are some of the impairments standing in the way of discharge to our patient. So we have decreased endurance, right-sided weakness, impaired balance, impaired gait, and spasticity.
Okay, so one example of an impairment that the patient has is decreased endurance. We speculate that the patient may have this impairment due to her history of heavy smoking. This impairment negatively compounds her other comorbidities and further complicates every task that she has to perform. Thus, it may impair her quality of life and impact her ability to participate in prolonged activities and be a safe community ambulator. Unfortunately, this impairment leads to a downward spiral in which decreased endurance may lead to decreased activity levels, which in turn may lead back to decreased endurance. So a barrier to the patient's discharge may not be able to effectively complete PT goals and activities such as performing home TheraX and walking 50 feet with a rolling walker independently to be a household ambulator in order to be safe at home.
As a result of the left CVA, our patient will have a right side weakness, right hemiplegia. So some things you'll notice with her, she'll have impaired prehension, grip strength. She'll have weakened rotator cuff muscles. That'll put her as a risk in the future for shoulder subluxation. She'll have difficulty moving her right side against gravity. So those muscles are now weak. So especially during gait, you might see something, a foot drop, so weakness of the dorsiflexors, and that'll negatively affect balance and gait. Then some barriers to discharge, activity limitations to keep in mind. She'll have difficulties holding and carrying her baby around the house. Household tasks involve gripping and holding things, so maybe she's cooking, that'll be a problem as well. And then she'll require an assistive device to support her body. And those strength deficits are even more difficult to overcome now due to her obesity.
Our patient's balance is impaired. She may present with such signs as decreased postural control, lateral pulsion with decreased ability to weight shift, and deficits in ankle and hip strategies. This puts her at greater risk of falls, which could not only affect her health, but the health of her child. Negotiating her environment becomes problematic. Simple activities such as transferring from a bed to a chair are difficult to perform safely, especially with the added weight of carrying a child. Changing diapers or bending over to place a baby in a crib tax the body's postural control systems, and these actions are further complicated by the perturbations of a dynamically active baby and increase a load as the child is extended away from the center of mass. If our patient loses her balance when she steps backwards or makes a turn, she is at risk for falls. If she loses her balance during any transfer, sit to stand, bathroom transfer, in the shower, or while dressing, it is a barrier for discharge, especially since she does not have adequate support system at home.
So another issue that our patient's going to have is obviously gait. As you know, ambulation is more difficult because of a direct result of CVA. Our main concern for her impaired gait is safety. She is at an increased risk for fall, like we just mentioned, due to lack of proprioception, weakness, and a whole list of other things. Her abnormal gait pattern, for instance, could cause a shorter step length on her right side, which will be a concern for us. Some barriers to discharge would be the inability to ambulate 50 feet, which is considered household ambulation, with a narrow base quad cane, and inability to negotiate stairs at home because she does have 3 steps to enter her house. Other responsibilities that she may have at home are household chores like laundry. She still has to cook, she still has to clean, and all this along with a baby. And she might not have adequate support from her family.
All right, so the last impairment we're going to talk about is spasticity. So following a stroke, many times patients will have spasticity, which is basically hyper-responsiveness of the stretch reflex. So this hyper-responsiveness will cause increased tone in the affected limb, and this increased tone will contribute to other impairments, such as decreased range of motion, decreased strength and postural muscle imbalance, gait abnormalities, and decreased motor control. So basically, the limb could be stuck in a certain position, and the patient will have issues controlling it, and that could lead to a lot, contributes to a lot of different issues that the patient could have with when going home. So certain barriers to discharge could be, just not being able to walk normally because of the increased tone. There's increased fall risk at home, and then also, for sure, there's difficulty caring for herself and for the newborn child safely. She won't be able to, change the baby, walk around with the baby, and he'll have, issues with balance because of this spasticity.
So just to summarize some of the barriers to discharge, we have standard negotiation with the narrow-base quad cane. So like everyone kind of said before, it's functional task is standard negotiation, so you're going to need to negotiate stairs, getting out of the apartment. Impaired balance leads to increased fall risk. So obviously you have to be able to walk, transfer from sit to stand, transfer in and out of the bed, in and out of the shower, things like that. Strength needs to be up to par in order to be able to ambulate and perform other functional ADLs. Self-care things such as using the bathroom, bathing, self-grooming. And then just keep in mind that with all these things, not only does the patient need to be able to do them independently, but they also could have a child in arms too. So it's important to get them strong enough to handle themselves and their child as well. So that's pretty much our presentation, so thank you guys. I think next we have public health.
Hello, my name is Rachel and I'm a Master of Public Health student. So public health encompasses a range of individual and population level factors that affect the health and well-being of communities and populations. So while this is an individual case, we look more at the community overall to improve outcomes. So we aim to target these outcomes in communities and not just an individual and advise these communities to implement these positive changes for risk reduction and health promotion. So the goal of public health research and programs is to determine which populations are at the greatest risk of disease and then develop these preventative strategies to try and reduce the risk. So topics that we focus on are very vast and include a range of things, and some of them are infectious diseases, environmental hazards, food safety, and chronic diseases such as in this case, and a lot more as well. So with the background of public health stated, kind of what are the things that we can do to actually cause change? So we monitor health of patients in the communities. We can conduct research. We also inform, educate, and empower people and communities, and then mobilizing community partnerships, writing policies to implement that change, and also linking patients to care are some of the things we do.
Let's keep that applause going. Give a hand for all the volunteers, your peers. All right. So we're going to switch it up. You've heard your fellow peers talk. You've heard faculty talk. Now it's your turn to talk. But before we dive into that, you're gonna break up into your groups. Actually, you're already broken up, right? So within the groups on each of your tables, there should be questions, which don't worry, they're right here as well. But you're gonna answer those questions. But before you do, and you start your assignment, each group make note of a timekeeper or appoint the timekeeper or / moderator to stay on time. We're gonna have 50 minutes for this assignment, and then afterwards designate one person who will wind up speaking and telling basically your answers to all the questions, and then it could be a group effort after that. But yeah, so starting now, take a look at these questions, collaborate. The whole purpose of this, take a break, stand for 2 minutes.
Although we are licensed independent practitioners, we specialized in low risk work. I'm sure we could coordinate care with a maternal fetal medicine specialist. And the other thing that strikes me as odd about this case is she's 38 weeks, right? So she's term.
Big thing is with medications, because she had a cerebrovascular accident, we have to put her on anticoagulants. What else?
too, especially because she's got a lot going on. And that's not only physical, but it's a lot of mental stress that's taking it out on her. So I could see that would be a great option for her.
Oh, it says she takes her meds most of the time.
Most of the time. No, she's a prime time BS'er. You gotta assume she don't.
No, they come in at
I think at the same time, yeah.
And we would just see what her current level of function is and ask her about her home and like figure out what if she's gonna need any kind of like adaptive equipment or what it looks like if she's able to go home safely. If she's gonna be okay.
Because they had a stroke. A lot of things we'll focus on is their success in their ADLs, so how they kind of take care of themselves. And along with that would come, any equipment that they would need for home. For example, we would take them into the bathroom and see how they manage themselves, comb her hair. And this is all before we even address what the presentation said about how she would manage taking care of her baby. Kind of work on her, I don't want to say compliance, but kind of make like a medication schedule or like talk about ways. Yeah. It's just.
If she smoked like 20 years, so probably she continued.
It's also important that we educate them as well.
Yeah, thank you. She needs assistance.
Let's get together. So the question is that what will be each discipline's role in discharge planning for this woman as she transitions from in hospital to home? So we would like to have a volunteer from each group. Perhaps that if you're satisfied with the answer, we move on to the next question. So let's hear from any volunteer from any group.
All right, so I'll go through a few of the disciplines, so then another group can take over, because I'm sure we're going to say a lot of the same things. So for DMI, they said that we're going to do a carotid exam, echo, what was echo?
For the obstetric portion, we mentioned a BPP, a biophysical profile, where we would take a look at the fetus and the placenta to make sure that the baby is also getting nutrients.
So then we also had Midwife. She just left, but she mentioned something that I haven't ever heard of. There's still one right here, but yeah. So it was a nurse-family partnership that they said that like obviously it's the third trimester, but they probably would have wanted to do this way before. And basically, they have a whole plan with the family and a nurse, and they have the nurse at home, and they work together. And basically, it just makes the whole pregnancy a lot easier. And she says that with all these comorbidities, she probably qualifies for it. So this is something that we should have happened beforehand and would probably help with the whole pregnancy process. And then obviously they want to determine if a C-section was possible, which they probably think it is at this point because it's 38 weeks. And then obviously assess the position of the baby and everything. I'm sure another group can talk about OT, PT, and PA.
All right, so let's hear from that group, perhaps from OT and PT. Go ahead.
Okay, PA, we said first and foremost, the patient needs to be medically stable to go home. If they're not medically stable, they can't go home. So first, the patient needs to be medically stable, and then from there, whatever medications the patient has to understand their medication and be compliant with their medication. So that was with PA. OT, so OT was going to focus mostly on IADLs. So can the patient take care of the newborn and take care of herself? Can she, deal with the diapers and cooking and things like that? And also just functional wellness and balance, being able to take care of those things on her own. And PT, for discharge, we basically was focus on the fall risk. Is she safe to go home? Is she going to fall? Does she need an assistive device? What's the proper assistive device for her? That's what we have for the those.
Thank you. Any other group want to suggest anything? How about that? So group number 1 or 2? Okay.
Group 2. Okay, so for OT, we also want to assess what kind of equipment she will need to use at home, make sure that she can brush her teeth, comb her hair, make a medical management, make her aware of how to manage her medications, which she has been non-compliant with so far. And then really assess, is she even ready for discharge, which was something that we all were kind of like, well, yeah, OT, PT, and midwifery, will we even discharge her? She's 38 weeks right now. We might want to induce her at 39 weeks because she's had a stroke. She also is at high risk for preterm birth because she's obese, she has a history of smoking, she's got diabetes, and she also with the stress of the discharge, she might have a preterm birth. So if we send her home and she's in this condition, how easily will she be able to get back to the hospital, and how soon after then will she even have the baby? Does it make sense to discharge her? So that's kind of an important conversation to have. And then PT, we added making sure she can negotiate the stairs because she has stairs in her home, leading up to her home. And for PA, we discussed making sure her BP is under control, specifically to avoid preeclampsia, running labs for preeclampsia, and having a conversation with midwifery on how soon to induce and whether or not she can tolerate a vaginal delivery, because that was her initial intention. Not whether or not she should have a C-section, but whether or not she can tolerate a vaginal versus, blood loss from a C-section, etc. So, DMI also said they would assess for thrombus in the umbilical vein of the fetus.
Any other suggestion? All right, group number
8.
Okay.
Okay. So besides some of the things that many of the groups already shared, I think it's important to assess, as part of PAs, assess if the patient has any hypercoagulated state. Maybe the patient suffers from factor V laden or anything that can create a clot. And as far as that, we talked with DMI group, and they, since the patient works as a secretary, so she's sitting down all the time, she might be high risk of developing DVT. So we could check maybe with the Doppler ultrasound to see if maybe there's any thrombus formation. And also in the echocardiogram to check if there's any intracardiac thrombus. That can also be one of the things that could put her at risk of developing a CVA later on.
All right, so let's move on to the next question, which is, what are your top 3 concerns? All right, it's group number 10. All right, let's hear from them.
Hi. So some of the things that we discussed as a group were to make sure that she continues to be medically stable, both the fetus and the mother, so that's continuous monitoring, as well as ensuring functional mobility around her home, making sure that she can negotiate the stairs in her home, as well as care for her child without needing any help. And then in terms of her actual stroke, finding the etiology of the emboli and then working towards preventative care, being that she was at high risk. She had, several things contributing to the stroke. And in doing that, make sure that if for whatever reason she can't return home independently, that she has the proper measures, whether it's family or her husband taking off from work, lined up so that when she does go home, she'll have the help that she needs.
Thank you. Any other group? All right, so let's hear from group 7.
For question number 2 or question number 3?
Question number 2.
Question number 2, okay. We mainly have the same things as question number 10. We're mainly concerned about safety. We're mainly concerned about safety and the health, and making sure that the health concerns are not exacerbated. We're worried about the imminent birth and making sure that she is compliant in her equipment and also compliant in taking her medication.
All right, thank you. All right, so if there is no addition for the question number 2, we're going to look at the question number 3. How can each discipline foster communication with each other to provide the best care for our patient? Let's hear from any group.
We're group 6.
All right, thank you.
So we said to improve communication, we could have team meetings to ensure that at least one person from each profession comes and discusses like the status of the patient, and we use language that we can all understand and not use jargon specific to our own professions. And we were also trying to figure out if there was a way we could coordinate some type of electronic forms of communication, but we didn't really figure out a specific way to do that that didn't violate HIPAA.
Any other suggestion?
Right here.
All right, group number
1.
1.
So our person from medical informatics brought up that we can utilize the electronic health record. So each provider will get a tab, and then they'll update the record with, accurate treatment, documentation. They'll be able to put in patient complaints. You'll be able to have access to the imaging of the fetus. As well, we could do a PT-OT consult. Together, we could go do an evaluation on the patient, assess her deficits, and then imaging obviously has to provide adequate comments so that everyone can understand what's going on.
Any other comment? No?
Okay, so the other thing that we were thinking of is making sure there's real-time documentation to make it the most efficient group collaboration, and rather than seeing 2-3 patients and then sitting down at lunch and charting, making sure you're doing it as you're seeing the patient so that whoever needs to see the patient next, they know exactly what happened, what's been done, et cetera, et cetera.
All right, so let's move on to the next question for the sake of the time. What is the broadest perspective on enhancing health in this community? So let's hear from the volunteer group first.
So we were saying that hopefully she can, because she's coming from Haiti, she can join a prenatal support group for these chronic diseases and her conditions, and they can discuss. This obviously, hopefully, would have happened before, so then she would know the dangers and the risks that she was at, and she would actually have a group of people that she could relate to and everything like that. And we would ensure, and it would also help ensure adherence to meds. There'd be prenatal exercises, communication with other women in the same position as her, as I said, and just overall education of the preventative measures and advocate this in the community as well and everything like that.
Thank you. Any other suggestion?
Okay, so our group wanted to know if this woman is typical of her community. Are the challenges that she's facing things that are common for other people within her community? So we can look at prevention and wellness programs, smoking cessation programs, programs designed to combat sedentary lifestyles. And that was it.
Thank you. All right.
Group 2.
Just public health brought up the centering pregnancy program. So looking at a program that is known to decrease a lot of these chronic conditions and also decrease maternity mortality, infant mortality, preterm births, etc. So having her in a place where she's supported by other women in those same conditions, women that are speaking her same language in the same space that she is important.
Are we good? All right, so let's look at the question number 5. What advocacy is needed for this woman, local and community-wide, and how does one or we access it? All right, group number
7.
7.
Okay, so for us, we want to increase support groups. We want to advocate support groups for people with obesity, hypertension, and prenatal care. We also want to increase education on tobacco cessation and nutritional information. Also, we want to get her in touch with financial assistance and get her in touch with the social worker and helping her with things at home.
Any other suggestion? Group number? All right, group number, public health.
Hi. So basically for advocacy community-wide and local Brooklyn, So what we propose to do, we talked a little bit to each group about a policy brief. And for this, we would be addressing our local and community leaders. So in this case, it would be Eric Adams. So kind of bringing this up to him and give support and get support from him, and then get that support from the community as well. So policies usually are more successful with support from both local and community leaders.
Another support group that she would need to consider is on depression. She's at high risk for depression, so and postpartum depression specifically, so a support group for that.
I also, to kind of expand on that point, I think the burden that she has from all these physical illnesses definitely take a toll. So I think in the process of gathering a physical exam and history, that you note how her mental status is at that point, because this is an extremely difficult situation to be in, especially with a kid on the way. So being able to just respect her mental health and make aware of it in case she does have any problems, and we can provide the right outlets for her.
Okay, thank you. All right, so let's look at the next question, which is what facility exists to help her with her special problems, issues, and how can she access them? I didn't hear much from that backside. Maybe somebody from there could talk. All right, go ahead.
So we covered several things that have already been discussed in other capacities, such as the new mom classes once she's had her child, support groups for her various conditions, for diabetes, for smoking cessation, for stroke survivors. And then in terms of access, it's our role as healthcare practitioners to be aware of what opportunities there are. So if we're informed and we're able to pass that along to our clients and patients by giving them paperwork, discussing with them, showing them websites, things like that.
Thank you. All right. Far back.
Hi, just as physical therapists and occupational therapists in general, we have to be aware of the different socioeconomic backgrounds that our patients may come from, and you can't just tell them, hey, you can't go to work anymore because you sit in your chair too long. You know, you have to give them proper education and exercises that they can do while they're at work. So she is a receptionist, so maybe we can tell her, hey, you know, every so often you should get up and walk around, or maybe at your desk do some ankle pumps or things to keep her blood moving while she's at work, because she can't just stop working.
Any other suggestion?
Yeah, group one. We wanted to refer her for a social worker so that she could have help applying for FMLA, for WIC, for CHIP, maybe later on for her child. But also, what I thought was really interesting was our midwifery person said that she would also need a lactation consultant, because since she's on so many medications, she needs help with like planning for when her baby is born.
Thank you. All right, so the next question is, what group didn't talk about it? Group what? Group, or didn't participate? What group didn't? Group 3, group 4? All right, your group. All right, so any new items you would like to discuss that we missed?
No, you're pretty good, actually.
Oh.
Amazing. I would say that you would probably, the main thing was to just prepare for the imminent delivery. So you would direct some sort of birthing plan, because a lot of the interventions we've talked about can actually be deleterious to the mom and baby. So that's a big one, but you did pretty good.
All right,
pretty good.
thank you.
Very informative.
Any other suggestion? Any other comment?
So we had some discussion about the patient's preferences. We kind of left out like what are the patient's goals, what does the patient want to do. So that's an important part to keep in mind. And also the patient's immigration status, wasn't clear if, that's an important thing to know, getting access to healthcare. So her immigration status is important. Another thing, Dean Lewis likes to talk about cultural competence. So just having a discussion on different cultures and what another culture could be expecting, what you might be expecting, and how that can happen, and when providing interventions to a patient, what to take into account and how to do it correctly.
Just to add to that real quick, so the support group that we propose for our policy, that would definitely touch on cultural competence. Since there's a lot of diverse cultures in Brooklyn, you would also have similar cultures within that support group as well. So where coming from a provider who's a different culture, you may not take their advice because they don't understand why you're saying no to a medication or why you don't want to do a certain procedure. So hearing from someone with the same culture could actually help either understand why it's important if that similar like pregnant woman did that procedure or took that medication, and just kind of overall improve their health through that.
One more. All right, let's do it.
Sorry. What's beautiful about this event is that we all get to like hear from each other, and I know from the midwifery standpoint, we often think like, oh, we're the only ones that think about informed consent, but there were like 2 to 3 other disciplines here that were like, you know, informed consent for this woman is very important because she's going through a lot. It's her first baby, she's got all these conditions, and she's gonna be, you know, changing up a lot of what she thought was gonna happen in her labor and pregnancy. So in making sure that we address all of the risks, all of the benefits, and the things that can, you know, happen going forward, and having informed consent. Informed consent is super important.
Our group just mentioned that you want to do some patient education with her. So you'll want to do some education on how to monitor her blood pressure, doing glucose monitoring. You might also want to refer her for pelvic floor therapy. And then lastly, you'll want to find out the source of her noncompliance with her medications. Was it due to monetary reasons or habit, other things?
All right, I thank you so much. For the sake of the time, we're going to have Professor Richard Sable, what? Public Health. All right, Dr. DeRosa.
Very quickly, but thank you, one and all. This is the first time the School of Public Health has participated, and it was a fantastic experience for us, and we hope for you. And we look forward to working with you in the future. And oh, by the way, anybody who wants to come and get their public health degree on top of all the other degrees, that makes you look really pretty out there. Okay, so at any rate, my special thanks to our public health students, and one of them who didn't say much because she's an OBGYN, so she knew all about all this stuff, so too. And she feels that the integration of treatment of the patient and public health, and how you get people to pay attention in the community and go after your public health, you go after your politicians to help make changes in the community is crucial. So we thank you very much, and my special thanks to my students.
Okay, so a very quick wrap up. First off, I want to thank you very much for being here and participating with us today, because this is really, as the dean said, this is a pilot project. We did it once before where the faculty took the lead, but you guys really took the lead here today. And from my point of view, it was a really good beginning. Now, we're going to be giving you an eval to fill out. You'll probably get an email tomorrow. Please give us feedback. We really want to improve this. This was a beginning. Because interdisciplinary communication, cooperation, there's no argument here, right? We all know, we all see the value and importance of it. And think about your own care. Don't you like it when you know that your doctor is communicating well with other health professionals? And we're all about to be health professionals, so it's like pay it forward that we go out there, 150 people right here, that this is in your mindset. You think about it. You think, when I'm out there, even if I'm doing home care by myself, how can I reach out to other health professionals? What can I do to be in better service to my client? And there's something else to consider. Not only are we all health professionals, we're also consumers, right? We all have to go to doctors and OTs and PTs. We get sonograms. So that ultimately, don't you also want the people that are serving you to be doing all that, right? So we got to remember that as health professionals, the arrows always go both ways. So without further ado, again, I just want to thank you all for really participating. Give us good feedback, critical feedback. If something wasn't good, share why it wasn't good. If you have an idea about how to make it better, share that with us. Try to really help us make this something that we can improve on. And we, as CHRP, need to also look at what other things can we do, not just a one-shot deal, right, bringing you all together now, which is really great, but what other things can we do during the time you're with us to build on this by maybe having cross-pollination in terms of maybe as an OT I go into a DMI lecture or a midwifery lecture, right, that we coordinate between the departments to share information on that level too. So any ideas that you have about that you think we could do to make things better, share that with us. You have brilliant ideas, and we'd love to hear from you. So again, thank you very much, and have a great afternoon.